Hey, just wanted to give you guys a heads up that we are discussing in this episode about MAID, which is medical assistance in dying in Canada, and talking about all of those areas. We got a great show discussing the pros and the cons of it, but I wanted to bring it up because we start talking into some of the areas regarding depression, or people who might not have a lot of hope for life. And I wanted to put this out, and if this is something that you're struggling with, maybe you feel like life isn't worth living, maybe you feel like you don't know where to turn, or you feel like society, your family, your friends would be better off without you, I want to let you know that you've got so much value, you've got so much life to live in, and we want to be able to help you. I want to encourage you, turn to someone that you love or loved ones you have, talk to them, let them know how you are feeling. You know, we have family and friends around us, and if you don't have someone around you that you can talk to, reach out to someone that can. We'll provide some information on the screen about calling someone. I also want to encourage you, maybe if you don't have that community or a community around you, I'm going to challenge you, you know what, go find a local church, even if you aren't a Christian or think church is weird. Go find a church that's in your community. Go tell them, hey, I'd love to chat with someone about this. Churches are there to help and there to show you. We believe that every single life has got intrinsic value, and you have something to offer to society. You have something to offer to people around you, and you do have a beautiful life ahead of you. So I want to challenge you, reach out to someone so that you can take the proper steps to getting the help that you need. Whenever you're dealing with death and people choosing to die based on circumstances, that's obviously people get very sensitive about it.
It was comparing us to California. Their total death rate, I think, is just over 1,000 right now, whereas ours is far north of 30,000. And so when I saw the graphs of Canada versus California, I was going, what is going on?
Would you say that expansion is concerning? When they use terms like mental illness or other parameters that people can go into this program, are they pretty broad?
One of the critiques that we have is that the eligibility criteria are...
If somebody is terminally ill and sick and helpless and they want to go, that's the real question at hand. And I think that's what most people think we're talking about all the time here. I'm picturing the worst case scenario. Like if it was me and I couldn't barely move or breathe or eat, and you're at the end of your life and you're just being kept alive in the worst case possible scenario, would you want to stay alive? David and I were just wrestling with this before we were starting the show, and I don't even really know where I fully land on it, but to decide what it is the real issue I find here. So we've got an expert in-house. We're going to wrestle with the concepts, debate, talk, and hopefully let the great ideas rise to the top and go from there.
Yeah, it's an interesting topic because whenever you're dealing with death and people choosing to die based on circumstances, that's obviously people get very sensitive about it.
For sure.
And I think...
And hopefully that's good.
Yeah, 100%. And it's worth talking about because I know there's been a huge ramp up in Canada in the last number of years with how many people are choosing this path. And I think as we'll dive into this in just a moment, it's actually become one of the top 10, I believe maybe top 5 leading causes of death in our country. And it seems like
I think it's top 3. Anyway, we'll figure that out.
But we've got a woman who's joining us. Their name is Rebecca Vachon. She's with Cardus, the health program director, and we're so grateful that you joined us today.
Welcome.
Thank you. How are you doing?
I'm good, and tied with the top five causes of death. So top 5, yeah.
She's already telling us
she's
the facts, which is what we want.
That's what we want.
Thank you.
And that was one of the biggest things that brought it to my attention. Was I actually saw a social media clip that maybe we'll find afterwards to throw on the show, but it was comparing us to California, who has very similar boundaries on this topic to us from my limited point of view.
I'm going to give you one stat to prove my point. Just one.
Go ahead.
It takes one. This is how ridiculous this is. Okay, you ready? In 2016, Canada legalized medical assistance in dying. So did California. California has the same population as the entire country of Canada. Okay. In that time frame, California has only MAIDed, meaning assisted suicide, 893 people. How many do you think Canada has?
I'm going to assume it's ridiculously high.
Give me a number. Come on, play with me here.
12,652.
Over 50,000.
Holy smokes.
Canada is a predatory behavior. They're trying to include children down to the age of 12, mentally ill, homeless, and addicts, instead of giving them palliative care.
And their total death rate, I think, is just over 1,000 right now, whereas ours is far north of 30,000. And we started, I think, around 2016, same as them. And so when I saw the graphs of Canada versus California, I was going, what is going on? So that's what's stirred me up, where I went, well, let's get some answers here. That's wild.
Rebecca, do you mind giving us an overview of MAID, kind of maybe where it started, and just just for our audience who might be uneducated, they've heard about it, or maybe they know someone who's thinking about it. What is MAID? Why is it here? And then we'll maybe dive in after that.
Right. Well, medical assistance in dying, or MAID, it refers to two things, actually. It refers to both euthanasia, which is clinician-administered death, so using usually a lethal injection, lethal combination of drugs, as well as assisted suicide, where the practitioner provides the means, the substance, but the patient is actually self-administering. In Canada, it's 99% euthanasia rather than assisted suicide. It is basically there are less than 7 cases of self-administered MAID each year. It's pretty much all clinician administered. And so this started, as you mentioned, in 2016, was in response to a Supreme Court decision that had struck down the original prohibitions against assisted suicide, against practitioners being involved in euthanasia. And it set up a legal regime according to certain restrictions that included that the death had to be reasonably foreseeable. It didn't put a date on it, right? It didn't say you have to have a terminal diagnosis of 6 months or less, or a year or less, like some other jurisdictions do. But it just had reasonably foreseeable death and a few other safeguards. But in 2021, again, in response to another court decision, although a lower court decision in Quebec that wasn't appealed, they created essentially a track 2, as it's referred to, where someone can be eligible for an assisted death for non-terminal conditions, non-life-ending conditions. So that includes disability. That includes living with a chronic condition. And so that has been introduced as well. And then they are looking towards expansion in 2027. It was actually supposed to be introduced already, but they've delayed it for MAID for mental illness as a sole underlying condition.
Okay.
And there's also been some talk about advanced requests made for mature minors. So there's the expansion is continued to be something that's looked at. But essentially, that's the lay of the land, and that's how we got here.
Would you say that expansion is concerning? Like, is there, like, when they use terms like mental illness or other parameters that people can go into this program, are they pretty broad? Is it a pretty broad way that people can go through? Is that also what's leading to the amount of people who are choosing this?
Yeah, so one of the critiques that we have is that the eligibility criteria are not well defined, right? So it's really resting on subjective criteria from the medical providers and the patient themselves. So, for instance, reasonably foreseeable death was interpreted ranging from, weeks and months to years and years. That's deeply concerning when you don't have those definitions. And especially when you talk about mental illness, for instance, some of the criteria, like it has to be irremediable. There's no consensus in the psychiatric community about mental illness irredeemability, right? Because there's always like new therapies, new drug trials, different things that can be an option. Yeah. So a lot of these criteria are very contested and create really an expansive way to interpret it. And we've seen each year that the number of MAID requests that are denied has gone down. So in 2022, which is the last year we have federal data on, only 3.5% of requests of MAID were rejected as being ineligible. So that's really a huge number of people that are being found eligible.
There's a lot of concepts here that I almost want to wrestle with, and because on one extreme ditch, and this is why I want to go through this as a whole. If somebody is terminally ill and sick and helpless, and they want to go, that's the real question at hand. And I think that's what most people think we're talking about all the time here. We're talking about the nuances and the slippery slope of the legislation or the lack of legislation, I think is probably where a lot of the errors come in. Because when you and I were talking about we don't know where we necessarily land, I'm picturing the worst case scenario. And like if it was me and I couldn't barely move or breathe or eat, and you're at the end of your life and you're just being kept alive in the worst case possible scenario. That's where my concept is coming from on this thing, where I'm going, would you want to stay alive? Would you want to be able to go into the next life? Would you want to stay in that vegetative state? I don't know. But you're saying, no, the parameters are so loose that we don't necessarily even know. And something I came across in your report is when people had the criteria of like, let's say foreseeable death or whatever it might be, one thing I found very interesting was that the reported reason for death was not MAID, which is very interesting. Yeah. And so there was, I don't know. So then what is getting the credit? If they have multiple comorbidities, what's saying it took them out? I don't know. I guess the doctor just decides. All of that seems very, very, very odd. But I'd love to wrestle with the concept of, is it something that should be allowed at all? Is there a scenario where this works, where it should work, where an individual should have the choice for themselves or not? I know what my gut kind of tells me, but there's so many nuances here that I'd love to wrestle with and find out, is it accomplishing what it should accomplish? I don't know.
What was the initial...
On the reporting... Just on the reporting element, I think you raised an important point. And just to clarify, so doctors are and practitioners are required to report MAID deaths. There's different ways that they do that, either through a federal system, and some provinces you do it provincially that then reports to Health Canada. So you do have this federal data on MAID. The challenge, and one thing that the author of the report points out, is that in different provinces, what goes on the death certificates may not include MAID. And that creates challenges, because then when you want to verify the number of deaths that are happening, right? Because this is all self-reported data. The data that is being reported by practitioners, the same people who would be held criminally liable if they weren't adhering to the law, those are the people that are reporting it to Health Canada or their provincial authorities. So when you don't have a mechanism to go in and say, review the death certificates like you can do in other countries and compare the data and see, are from multiple angles, this is actually what's happening, that creates problems from a researcher perspective.
Well, I actually know someone who experienced that. I know someone in my family side of the world that was told it was due to the issue that the person was dealing with, only for them to find out 6-7 months later that actually was MAID. Then no one in the family knew. And that's bringing up a whole new set of emotions and trials 100%. For them as a family to try to process through. And they're looking at legal, going, how was this decision made? We weren't a part of it. If none of us knew about it, was our very weak, vulnerable family member the one who was not in a full mental capacity to deal with this decision? They decided, and then it was it was done. And so I from seeing that happen, I'm going, holy smokes, I can't even imagine the emotional toll that is on the family and everyone, but also the legal implications. Now they're looking at this going, who did this? Who decided? Was it coercion? Is that how you say it? Who made this happen? And so there's a lot of hurt and pain coming from that now.
That's interesting to me, because you have rights as the individual, and we should talk about maybe that after, about what is the right of the individual in that. And obviously you have the family aspect of love, and you want to be involved, but also you have the right of the individual to choose. But if they're incapacitated or they aren't in their right mind to make those decisions, you need to have people who know them. Like, I think you mentioned this, actually when I was reading some of your points about family doctors, some of the points about making this better, someone who knows your history, or someone who cares for you and wants the best for you, assisting you. I have a question, Rebecca. Actually, any comments on what Jeremy was saying or what I was saying before I jumped into my question?
Yeah, I mean, I think there's a broader discussion there about the individual and can this be brought in for these individual cases? And that was sort of the approach that was taken with the Supreme Court decision, with the legislation, is like, we can make this quote unquote safe for vulnerable people who might be subject to coercion, who might choose it for social suffering reasons rather than, that they have no other medical options. But the problem is, by introducing that, are we creating a situation? Are we within a social system where there's going to be an increased risk of death for those vulnerable people. And I would argue that yes, and we're seeing that happening. And there's really not a way to adequately stop that when you have this kind of program in place.
Rebecca, if I wanted to partake in this program, what is the process I would have to go through? And what would that look like practically? Like me showing up to my doctor. Can you walk us through what that would look like and also comment on some of the timing that would take place?
Right. So it would depend under which criteria you're eligible, whether it's a track 1 or track 2 case. Do you have a reasonably foreseeable death or not? And so it involves 2 assessors, and they need to go through different criteria to ensure that you're making what they consider an informed decision to be, and that you are in a situation where your suffering is unbearable for you and you're not willing to do other alternative things to address that suffering. And they took away the safeguard of a 10-day cooling off period, essentially, for track 1 cases where you have a reasonably foreseeable death. Okay. So that means that people can receive MAID a lot faster, which I think is really problematic, because you might be in a place where many people who face a difficult diagnosis, who face a moment of extreme suffering, sometimes the response is, I don't want to live anymore.
Yeah, you can't think straight.
Sometimes those things can be addressed, right? Same with mental illness. Like, someone can have depression, and through the proper treatment, that can be addressed. So that's an issue. With track 2, there's supposed to be a 90-day waiting period. So these are people with non-terminal conditions. However, those can be waived if they're concerned that someone will lose capacity. There's also ways that practitioners will turn track 2 cases into a track 1 case. So there's ways that safeguard doesn't really work as well in practice as it does theoretically. When you get to the end of the process, the practitioner, will, again, it's primarily euthanasia, will provide a cocktail of lethal drugs that end that person's life prematurely.
Do you know when you said 2 assessors, who does that fall to typically? Would that be within the doctor's office that I go to, or who does that fall to?
Yeah, so it can be doctors or nurse practitioners that provide the assessment and provide MAID. There are supposed to be independent witnesses to make sure that consent is there. You're supposed to consult with an expert if, say, the doctor that you go to is not an expert in your condition. So consult with someone who has expertise in that. The problem is that again, these are very nebulous, kind of ambiguous things. So let's say someone is living with a chronic condition that is causing them suffering, but it's not really, like we've seen these cases in the media, it's not really the condition, it's more that they can't get adequate housing that addresses their needs, or they couldn't get a ramp for their wheelchair, these kinds of basic things. So if you don't have someone who, like a social worker, for instance, or people who have specific expertise in understanding the social and psychological situation that they're in, and you just have someone who's an expert in, I don't know, just, mobility challenges or something like that. Like, that's not really going to actually ensure that options are being presented. A person has to be informed of, say, palliative care and other alternatives to address their suffering, but they don't actually have to have tried them. They don't actually have to have a history of trying that. Crazy. And again, that's really troubling because, for instance, palliative care is so badly understood, right? People think palliative care and they go, oh, that's right at the end of life. I don't want to deal with that because I'm not ready to die yet. The reality is palliative care can be used in parallel with curative treatments when you're still trying to fix the problem, to fix the disease. And it should be introduced at the time of diagnosis of a life-limiting or life-threatening condition. The problem is it's not in the majority of cases. We have a major issue in Canada with getting timely access to palliative care for a whole variety of reasons. There's also a lot of access issues in rural areas, remote communities, different marginalized communities. So when you have these kind of systemic issues in handling suffering, whether it's disability supports or palliative care, and then you're introducing MAID as though it's a solution, that creates, I think, a lot of ethical issues when you start thinking about things like autonomy and such.
Do we even have capacity in the palliative care system in Canada?
Palliative care is actually a very cost-effective approach because it is oftentimes lower intensity interventions. And so it can actually be really economically, really an economically viable program. Some of the challenges are that we don't have national standards. We don't have the same kind of national curriculum to make sure that people are being trained on when you need to refer for a patient for palliative care or the kinds of options that could be available. So sometimes people look at palliative care, it's like a doctor might say, okay, I'm going to prescribe an opioid that will address it. But palliative care is a holistic approach to care. It's supposed to address the needs of the entire person, spiritual, psychosocial, relational, as well as physical. And we know that with MAID, a lot of the suffering that drives people to choose it isn't even necessarily a physical symptom. Sometimes it's the fear of pain, right? Not even the present pain, but fear of that, fear of going through this, the loss of, participation in some meaningful activities, the fear of being a burden to other people. And so those are things that we really need to address as a society rather than having the state provide a premature death to the person instead.
Yeah, I find this topic is it's so hard to think through, and it's such a heavy topic. Like, I'm not saying the names of the people because of the sensitivity of the topic, but another family member of mine during COVID went through a very long and lengthy sickness and got to the point where she wished she would die, and that's not like her at all. But it got so bad so long, and now she's actually on the other side of it and completely healthy, doing great and incredibly well. I never would have predicted that she could have ever gotten to a place that she ever wished she would want to die previous to this. But that's how dark and horrible what she was dealing with was. And so I'm glad that she didn't have very quick access to it because she couldn't see past it, and most people can't. And that's what I keep going to those types of scenarios. Like, I'm a pastor, and one of the things that I've done is I've visited a lot of people in palliative care. And so I've seen the conditions of different palliative buildings, and some of them I'm going, gosh, I hope I would never be here. And there's a few I've been to where I'm like, these are beautiful, and it seems like the care is nice, and the rooms, and some of them even have like balconies, but the experience is something that I would want to question for standardization and how people are treated, or what's the communication. It's such a huge topic. It's almost hard to explore. I find it's not black and white, and there's so many nuances to go through. It's interesting. The thing that I find, and maybe you can speak to this, is how come we are so much higher in MAID deaths than anywhere else? Like, it's without question, we are growing at a rate far, far exceeding any other place. Am I accurate in that?
Yeah, so the report that we recently released called From Exceptional to Routine talks about how we have become the fastest growing assisted dying program in the world. We're not quite the top in terms of the number of MAID deaths as a percentage of total deaths. That still is the Netherlands. But the
that's
Netherlands
as a percentage of total.
Okay. Yeah, percentage of total deaths. Yeah. So compared to the number of people who die from other causes, MAID in Canada as of 2022 was 4% of total deaths. The Netherlands in 2022 was still surpassing us at 5.1%, I believe, just over 5%. But the Netherlands effectively decriminalized euthanasia in the 1980s and then legalized it in 2002. Canada, 2016. So
we're
the
fresh.
ramp up.
But no, I have stats here. What's your thoughts on this year? Because I looked this up yesterday, that we legalized it. Total deaths in Canada, euthanasia was legalized in that's Netherlands. You're correct.
It literally says
It was under the tab of Canada, and my mistake. No, you're right. You're exactly accurate.
Yeah.
Go on.
you let her go on.
I'm sorry.
Yeah, so just the rate of growth, we're really unique in the world if you look at other countries. And you mentioned California earlier, and California brought in assisted dying in 2016. We have a comparable population size, Canada to California, but the rate of growth has been almost flat there. Like, it's still been going up, but like much flatter line than Canada, which has just been, shooting vertical. And there are differences. Obviously, it's not an apples to apples comparison. California introduced assisted suicide only as opposed to euthanasia. But that raises other questions of why did Canada opt for a program that's associated with higher rates of growth rather than an assisted suicide program, for instance, that's associated with lower rates of growth. So a lot of interesting comparators and really makes that comparison very striking when you look at how we compare to other international jurisdictions on this. And
it's interesting. I find, why is it, so the assisted suicide stats are far, far lower than the medical administration of it. And why is that? Like, if the person, I wonder what the psychological difference is in that. They're both wanting to die. They don't want to do it themselves. And I guess, do you have any? Can you speak to that? Or seems strange to me if they're wanting to.
I don't have the ability to prove why it's happening. I have, musings, I guess, speculation. I think that there is a psychological difference between doing something yourself, like taking that responsibility and administering death yourself, as opposed to the sort of institutionalization of that, when that responsibility goes to a medical professional. You've already kind of signed up for it. They're there. Everything's in place. I think that can be some natural pressure there to continue with that, whereas if you yourself are responsible for it. So I think there is probably that sort of cognitive difference in terms of how you approach it. But it's very hard to figure out how you would study that, right?
But it's telling of something. It's telling of the human spirit still wanting to possibly continue on or fight. What an interesting statistic, eh? Because California, since 2016, says here between 2,300 to 2,500 individuals but just as you've pointed out, it's assisted suicide, whereas it's not euthanasia. So
I'm still kind of getting my thoughts together on that.
I know. That's how I feel about this whole topic.
I have musings like you're saying, Rebecca, and I feel like I don't want to articulate them yet.
That's how I feel about this whole topic. And to our viewers, like, I'd love to hear from you if you have experiences or concerns, or let us know. Comment below, follow. Let us follow your story, because we go back to our comments all the time, and we want to hear from you guys and see what your experience is on these types of topics. We want to explore the topics and hope that the best policy rises to the top, and that we can get Canada into a position where it's got great policy, which is just essentially good ideas. But it's a topic that I find is such a hard one to wrestle with. But I can't ignore our numbers and our stats. They're just off the charts. It's crazy.
Rebecca, can you bear with me for a second? I'm just going to try to articulate a question in a run-on sentence here. I can understand that there is, and I can see this side, a sympathetic and empathetic side coming at this for people who are truly, you can call it maybe living a bit of a torturous life, where it's just there is no function, there's no joy. People might say loss of dignity in how to live. I can imagine if I was in a position where it's like you felt, not just felt, I don't like basing things off of feelings, because feelings, I think, do cloud judgment. But if I was actually in a place where I'm useless, and I had conversations with my wife and my family and saying, like, I'm a burden on you and all this other stuff, and let's say you live a good life. It's hard to even paint that picture. I feel weird even saying that.
Of course.
But if you got to a position, I could understand at a certain point why people would consider that. Can you maybe take us into, again, this might be speculation on your part, but when this was introduced, what was the goal or the reasoning behind it as to why this is a solution, why this is a good thing to introduce into our country? Can you talk a little bit about that? Is that...
Yeah, so not a legal scholar. Let me premise it with that. So in terms of
just three friends having a conversation around a
proverbial
table.
So I think one of the really interesting things about the decision was this idea that the right to life included your ability to kill yourself or be killed by someone else, because in the cases that were before the Supreme Court, one of which, for instance, was a woman living with amyotrophic lateral sclerosis, or ALS, was the concern that the court had was that people were going to kill themselves early because they lose their ability physically to kill themselves later when life became intolerable. So this would actually prevent premature deaths by having practitioners involved, essentially. And look, like my own aunt and great grandmother died from ALS. I'm not going to romanticize suffering.
Yeah.
Okay. It sucks.
Yeah.
Death is hard. And being in those situations where you are losing bodily function or losing capacity, that is really a difficult place that people are in. And I sometimes receive messages or phone calls from people about their personal experience or their family's experience. And you're right. Like, I think we absolutely should be empathetic, because we're all going to find ourselves, if we haven't been in that situation personally, or our mom or our dad, we're going to be at some point, because that's unfortunately, or fortunately, depending on how you see it, just part of the human condition. The question that I keep coming back to is, what should society's response be to suffering? Do we end the life of the person who is suffering, or do we try to address the suffering? And I think there's a really interesting parallel when we come to suicide prevention, right? What is our approach to suicide prevention? Yeah. Do we prevent it? Do we try to address the things that are causing that person to desire to end their life? Or do we facilitate it? And that's been a really big criticism from my friends in the disability community, actually, is that for, a person who's able-bodied and experiencing, say, a mental illness or a temporary sort of situation, people are going to try and prevent their suicide. Whereas there's so much ableism in the medical system, and even ableism within, I think, the Christian community and within our own hearts and souls, where we assume that people who have different capacities as us have a lower quality of life, and that they won't want to continue living in those situations. And we've seen actually studies of doctors that bears out. The doctors will assume a worse quality of life for a person living with a disability than the person themselves. Yeah. Also know that there is a period of psychosocial adjustment that happens. Let's say someone gets into a car accident and becomes paralyzed. That's a huge adjustment. And if you look and you ask them at that time, do they want to continue living? Probably a lot of people aren't going to want to. But then if you ask them about a year afterwards, their satisfaction in life is basically on par with what it was before. There's been an adjustment. Life is not the same. Doesn't mean you don't have a grieving process. Absolutely. But that doesn't mean that their life is not going to be meaningful after that. So, it really comes back to that for me. Are we going to prevent suicide because we believe that that person has dignity and worth no matter what they're living with, and we're going to try and journey with them through that and be there for them? Or are we going to facilitate, and in Canada, a state-facilitated provision of suicide?
I think that was really well said.
Yeah.
Really beautiful, actually, because you're talking a lot about this. First off, humans are generally, we're pretty adaptable, but this constant quest for hope, right? It made me think of when we've gone through some stuff, and Jeremy and I we're brother-in-laws, if you didn't know, and we share a big family. And when you go through like a serious death, or you go through a serious loss in your family, you have that period where it's like you feel hopeless, but you eventually come through, and then you start finding ways to find hope and purpose and reason again in life. And I think a lot of people, you brought a great point for people, that we can maybe prematurely judge based on their condition in life, that think, oh, it's not as good just because it's not measured the same way I measure. But that's actually probably quite naive of myself if I pass that judgment, because even having friends who we've seen who've gone through, and we have friends who've they have a beautiful baby boy, right? That's gone through a couple things, and you see, it's like, well, you see the joy and the love that comes from that child, and even though it might not be operating the exact same way that we would, it's like, no, they have just this beautiful quality of life as well, and just looks a little bit different. And anyways, I just thought that was a beautiful point of what you said, because that's something I think that needs to be taken into consideration, of this constant pursuit of hope, and back to MAID, about, it seems like, well, we've obviously been a little bit critical in some of the questions we're asking, but the wide posts that are there to slip through, which makes it more of almost more of a convenience factor, I would say, for some people. Not to throw any stones, but anyways, musings. I don't know how to.
And it creates a lot of vulnerability. I mean, we've seen cases of someone at Veterans Affairs, when veterans were calling in looking for assistance with like PTSD and all that kind of stuff, they were being told, well, you could pursue MAID, or a Paralympian and veteran with who needed a wheelchair ramp, the amount of time it would take to get that was offered MAID. Or a gentleman who needed assistance living at home repeatedly offered MAID instead of that assistance. And that is so deeply concerning, because that was exactly what we were told was not going to happen.
Is that a result of a bad system, or is it a result of a bad character within the system, or is it kind of a combination of both, do you think?
I think there's definitely systemic problems when you have that eligibility that's really wide open, when you don't have, for instance, restrictions on people raising the option of MAID, especially when people are at their most vulnerable. New Zealand, for instance, prohibits doctors and clinicians from raising the possibility of MAID. And I think that's so important, because someone I know who wrote a really wonderful essay for our magazine Comment on this, when he was given a terminal diagnosis, he was offered palliative care and MAID at that moment of vulnerability. And this happens to be someone who's a psychologist who knows, the science, who knows the impact of diagnosis, and so was able to kind of navigate that. But even just the impact of being offered MAID at that point of diagnosis, I think can be really problematic.
For sure.
So, I think there's a systemic issue, but then I think there are some cultural issues that we need to address, like ableism, like how we approach vulnerability and dependency, and see those as somehow something to be avoided rather than something that's part of being human, and something that we need to respond to and accept within ourselves and accept within others. So I think that there's probably a bit of both in that situation.
The thing I'm concerned about as we're talking through this is I can see this like with the path that's currently on. We often say,
play this movie out, or if we keep going the direction we're going, where will we end up, right? You should be able to have a logical conclusion about, hey, we're going to end up this direction based on what we do. And what I can see for sure in this, as the convenience factor, as the wide gates to go through, is that it's not holding on, in my opinion, to the inherent value of life that we have. It's almost just putting it off as, well, life isn't that valuable, it's not worth fighting for. And I get there are some instances where you might think there's nothing you can do, but to have it that broad, you're essentially saying, well, yeah, you know what, it's tough, so it's not that valuable. And we end up decreasing the value of human life, which I think is a very scary road to go down, because obviously I think we all believe that there is inherent value in every human life, and it's worth fighting for. We've seen that in cases. You brought up some cases. We've seen cases where it seems hopeless, but you've seen the other side of it when people push through and fight, and they go through that. And suffering sucks, but there also can be some good that comes out of suffering, or that comes out of hard times and all that, if you push through. But
not just that you push through it, but that other people are fighting for you.
Yeah.
And I think that's so important, because like, as someone who lives with a mental illness, with the coming expansion, and when it was going to be expanded and then was delayed, it's so bizarre to sit and think, oh, I would be potentially eligible for this. But I know that in my position, I have so many people in my life that would fight for me, that would do everything they could to be there for me if I was in that moment where I was just like, I don't want to live anymore. But for someone who doesn't have those kinds of social supports or is encountering, ableism in the system or other vulnerabilities, are they going to get that kind of response? I'm not confident in that. In fact, I'm quite sure that they're not, because we're already seeing examples of this. So that's something that really is sobering to me, is how not only do individuals need to get through things, but also what's society's role? Like, what is our duty to one another?
For sure. It's a great question.
We have ethical obligations to care for each other, and we're relational people, right? Like, I'm getting on my little soapbox here, and I apologize.
Great. It's a good point, but it brings me, like, do you think, and we've okay, I just want to ask this question, and it's okay if you say you don't know, but do you think money has a part to play on this? That's something that, as I research this, I find it always comes up, where it's an expense on the system, and so the system, it's far cheaper to do this instead of palliative care. Now, that's a very harsh way to put it, and nobody would probably ever say it that way. But is that a variable here? Is that?
Yeah, so I don't want to impugn people's motives, right? Like, do I think that people go into politics because they're horrible people and they want to destroy people's lives? Do I think people go into healthcare because they want to, end people's lives? Absolutely not. I think, generally speaking, people are probably providing MAID because they want to respond to suffering. I just think that they're going about it in a wrong way. But we actually will have a paper coming out either later this winter on the economics of MAID. And part of that is showing that because of the cost savings of MAID, there can be a perverse incentive. Now, that, again, we're not saying that
is the driver,
is the motivating factor, but can you really take that out of the equation? Yeah. And I think it's very difficult to do so. I think that there's always going to be that kind of subconscious pressure there. And that's really worrisome, because ultimately it's a lot less expensive to provide someone with a premature death than to provide them with assistance in living or just, the high quality care that they need.
Well, and that's what stands out to me when you see that we have 10 times the deaths of California with the similar population. 10 times, where I'm going, what is going on? Like, how is there 10 times in our country? There's something happening that's just odd. And obviously we know it's the nuances in the eligibility and so on and so on and so on. But
the way I would put it, maybe this helps it be a little less crass than that, but unfortunately, the cost is a part of life. We all take that in consideration. Like, if my wife and I are pursuing something medically, and let's say we feel like Canada can't meet our need, we're going to try to pursue it elsewhere, but we have to take the cost into consideration. And a lot of people are faced with the reality that they won't pursue the proper health thing they need because the cost of it, they can't do it. And it is a part of the equation.
But even along that same line of thinking, I would have maybe anticipated an American healthcare system maybe have higher MAID stats because they don't have universal healthcare like us. You know what I mean? So meaning,
I would almost think it's the opposite.
But what I'm saying is if you're a medical burden and you can't afford it because you don't have universal medical anything, you would garner a bill of $500,000 in no time flat to $1 million, or even far spirit. To have a baby in the States is anywhere from like $16,000 to $30,000 to just deliver a baby. And so that's where I would have thought, in those type of medical bills, that this might be a much cheaper option that people would maybe resort to. But we're not necessarily seeing that.
Interesting.
It's just a speculation, but I'm surprised that we don't see that.
Rebecca, can you tell us on some of the things, because I was reading through some of your guys' stuff at Cardus, what are some of the things that needs to take place, in your opinion, that's going to help this be more effective and maybe more stringent to making it, I'll call it a more effective system, or better, whatever word you want to use?
Yeah, I think there's 3 sort of basic things that we could do. One of which is, we don't have a national review body that looks at MAID. We have the Health Canada reporting, but the reporting, they don't have the authority to, for instance, if they see compliance issues, they're not there to monitor for compliance. They're not there to refer to, say, a criminal prosecutor or the police if there are issues. Whereas pretty much every other country in the world that instituted assisted dying, they brought in review bodies at look at this. We have some of that happening in some provinces, but it's not often very transparent. So having a review body that can monitor for compliance, that can study these things, I think would be a good first step. The second thing would be to shore up those eligibility criteria, really get into more objective criteria that can be measured in more clear ways, like what does reasonably foreseeable mean? Can we put a date on that? Can we put some parameters that are more objective? And can we roll back these expansions when we keep on expanding, but we have such a rapid rise of MAID? Maybe we should be pausing on the expansion button to figure out what is going on and address some of those root causes of suffering. And that would be the third thing is, can we really get a robust palliative care system? There was some federal attention to a palliative care strategy and framework initially when MAID was introduced, but that political attention has sort of fallen off. Can we reinvigorate the discussion on palliative care and ensure that everyone has access to that care? Can we ensure that disability supports are being provided? And I think that would go a long way to addressing root causes as well.
So if you're willing to give us an answer on this, should MAID be kept around or should it be disposed of? Or is it not that clean cut?
I think probably my position has come across pretty clearly over the course of our conversation. I think I said this earlier, even if MAID could be an ethical option at the end of life, could it ever be put in place in a way that's safe for other vulnerable groups? I don't think so. And then the broader question, is it ever an ethical thing to include in the healthcare system? And call me old-fashioned, but the Hippocratic oath of the principle of do no harm rings pretty true to me. And so having a system where doctors and nurses and the system is dedicated to preserving life and providing you with, care throughout your life and not providing a premature death is where I'd land on that.
I wanted to ask that question because how does this change the doctor's function, right? With their, as you mentioned, what they are there to do is to preserve and to help and to aid. And now you're bringing a part of their arsenal is to actually end, which is, I just can't imagine. I'm sure some doctors it doesn't affect, but I'm sure other doctors it does.
I don't think they would see it that way. They'd probably see it as sympathetic aid or care. That would be my best guess at it. But
I bet you there's a lot of doctors they have patients that come in who want it and they just feel like, I guess they have to sign off on it, right? Can any doctor sign off on it? Can any doctor in Canada do this, or how does that work?
Yeah, well, there are training programs, but it's not a requirement under the law that you've been through the training program or whatnot, as far as I understand it. Doctors do not have to provide MAID. They can. The patient can go elsewhere to another doctor. That actually creates problems as well, because some patients that are rejected for MAID can find someone else who's willing to provide MAID. So you kind of have this doctor shopping situation.
But it has to be another doctor though, right?
Doctor or nurse practitioner, yeah.
Okay.
Yeah.
Are they incentivized with this in terms of remuneration?
So yeah, I mean, it's not like it's something that they do pro bono. The pay structures vary in different provinces depending on how you bill for it. So one critique that I have is, for instance, in Ontario, palliative care billing codes are used to include MAID services, which is problematic because then funding that's supposed to be specifically allocated to palliative care is also then going to something that is distinctively not palliative care. So yeah, I think that's concerning. The fact that there are some practitioners that have basically made their entire career now purely about this, and that financially can do that or are selling books based on their experiences, I think that is awkward at best.
Yeah.
So yes, but I mean, your fee structures would be similar to providing other medical care.
Yeah, okay. That was, that's That's a really interesting take on
That's
it too.
worth exploring.
You have helped us a ton.
Yeah, you really have.
It's funny because last number of days, Jeremy and I have been talking about this and having chats, and normally in our research meetings that we have with our crew, like you and I were both kind of quiet too. Just like, at least for me, I was just like, having a hard time even thinking through this, and like normally I like to be on a position on something. Here's my position. I figured it out. Here's what I think. And this one I've just been like, But you've helped me a lot in terms of helping me understand the system, the pitfalls of it, where it's going wrong, what we can do better. Like, it's been very eye-opening for me. I believe for the viewers too, for people who don't know, that this is so important. That's why we call the show Citizen, because we believe that citizens are the ones that determine the future and direction of where our country goes, right? We're the ones that are supposed to keep our government the government's beholden to us, not the other way around. And we have to be educated on different policies that are coming through, why things are coming down the pipe, so that we can, as citizens, part of our duty and responsibility, I believe, is to care for our neighbors, care for the other citizens in Canada. And things like this, when they go down, if you're not really aware of it, I would argue, like, I think you need to care a bit more.
For sure, because these play a part to the future generations and culture and standards, and what we do now sets the precedent of what's to come, and that's an important thing that we must understand. So you've helped me a lot too, Rebecca, so thank you for joining us today. I imagine this is a heavy thing to always constantly probably talk about or think about, but grateful that you do, so thank you for that.
Any final comments, Rebecca, or things you want to wrap up with? Or I think
Yeah, I mean, if people are interested in learning more, I encourage them to go to the Cardus website and our health program. We have research and polling on a number of these related issues. And then for those who disagree with the positions I put forward today, who maybe have personal experiences or even are thinking about something like MAID, I hope that we can also find the common ground on, let's address suffering so that people are not choosing this because they don't have adequate support, or they don't have adequate palliative care, or they feel like they're a burden. I don't think those are anything that people really want. So there are areas where we can pursue better options together.
Yeah.
Great. Yeah. Thank you, Rebecca. It's been awesome having you on. We enjoyed it. We'll definitely have you back to explore more of this, which is good.
Did you understand my point? Like, imagine, because you remember when you talked about in the concept of MAID, the burden that you might be on your family? Yeah. That's the point I guess I'm more or less making with the American system, is if you knew your terminal illness was terminal and you knew you were dying and you knew you'd rack up your family $1 million bill in your death, that's what I'm surprised about. That's what I'm saying, is in that medical system, you would get $1 million bill. Oh, that's your point. That's my point, is that if that was being added to the everything else you're dealing with, and you knew you're leaving your family with that kind of bill, I'm surprised in that environment of the medical system that it's not more prevalent. I guess that's a bit of way to say it. Yeah, I get that. That definitely would weigh on you, right? Yeah. You don't want to, as you go, you want to screw your family financially. But isn't it interesting though that the self-administered versus doctor administered is so drastically different, and that's something I almost want to explore. What's in the lethal injection, by the way? The cocktail? I've seen a few online in this conversation where essentially it's like a cocktail drink and they drink it. I don't know exactly what it's fully made of, but I've seen one where the doctors were talking through and they mixed it, and then they literally videoed the girl drinking it. And then they sat next to her, and I felt so morbid. I felt so heavy watching this, and the families were around, and they didn't video the person passing away, but let me ask you a tough question. It felt so heavy, man, watching it. I couldn't even believe it. You have a loved one, and they want to go through this. At what point would you agree with them on it? I don't know if I ever would. I don't know if, I was trying to make a scenario where I could maybe see myself, because it's easier to do it to yourself. I don't know. Because a point I said to you the other day was, as a father, and my children are 10, 7, 3, and everything I say and do now is a lesson for bad or good. If I overreact, if I yell bad, if I'm peaceful and there's a lesson in it, it's good. So in every action there's a lesson, and that's something that I've heard Leon say in his messages, I want to teach my children
how to die honorably,
how to die honorably. Well. And I just don't ever want to convey surrender of any kind, even like, and I understand there's ignorance in my lack of experience of pain and suffering. I get that.
But you know what? Fundamental beliefs, what you believe, will also determine a lot about how you approach this subject. Yeah. Right? Like if you come from a religious worldview or you come from a atheistic worldview, or that's going to affect the angle you take on this too.
But the point that I more or less wanted to emphasize is, and if anyone can, isn't it interesting though, how the human spirit would rather have someone else do it? You know what I mean? That little nuance, that little detail. You know, it's interesting.
On the overall cases, have someone else do it. I don't want to do it to myself. Well, there's a fear part of it too, I would say.
Like I almost wonder imagine if it cost the MD office to do it, how that might change things. Like imagine if it was a bill. So if you went to your medical doctor and it was a $5,000 bill for you to request it, what would our statistics be? I don't know. I think they'd be very different.
Or it's not included in your health
coverage.
Insurance.
Yeah, maybe it's not included in coverage. Would it be very different? I think it's manipulation to offer that in a situation of diagnosis of anything terminal, like Rebecca had mentioned, where if you were told you're terminal, you have a sickness, and you've just been told you have cancer and you're dying. I was trying to find the graph, but there's a graph that I came across. I was at a business meeting, and the guy was presenting something, and he was talking about how as humans we are just so naturally against change, good change, any change. And he talks about there's a natural form of it's like a form of grief, and if maybe the producers can find it, and it essentially says when the news is delivered, you go into this decline of happiness, so low, to the lowest you've ever been. And what's wild though is in that graph, it's got something, it's got a name to it, something's chart of grief. And in this chart, almost immediately after the grief period, it exponentially shoots up into optimism. And it's the human track for change. When we go through change, if I'm your boss and I say, we are getting rid of this and going here, you will have an initial response of a no, I don't want to. What are we doing? We're screwed. What's the point? Blah, 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 blah. And then eventually you'll step into all right, I could see the future in this. I could see where we're going. Yeah. And this same graph and chart happens when we grieve, when we lose a loved one, or when we get diagnosed, or when we, et cetera, et cetera, et cetera. And so to have that news delivered at that point, when you're not even at the lowest yet, you're at the lowest when you go home, when you're by yourself, when you're going to bed, when you're alone, when you realize the burden and all these things are coming up to you. You've just been told at that lowest, on your way to your lowest, you could release the burden from your family. It's like that's manipulation. They should have a 10-day, 12-day, whatever the medical best would be to tell someone that
maybe
option.
Even that 10-day grace period, track 1 and track 2.
Getting waived?
No, I was going to say like make them longer.
Oh, for sure.
Like, because my brain is still computing a lot of what we're talking about. I feel like I'm shifting a little bit already in this exact same episode of what we talked about is, we've talked lots, emotions cloud judgment.
Of course.
When you're hopeless, I've never been in a position of utter hopelessness, but I've been in sectioned off areas of my life where you feel like there's a lack of hope, or you feel overwhelmed in certain areas. But then when you get a glimmer of hope, you find a way forward, because you have a chance to settle in where you're at. And then once the emotions subside, your brain starts to problem solve and think, what can I do to move on? And you're actively, naturally, it's one of our humanistic tendencies is looking for that survival, that way out, and survive the proverbial survival mode in different areas. How can I move out of this area, whether you want to talk about finance or health or whatever. My point in saying that is that emotions cloud judgment. And I'm doubling down what you're saying, is that when you're given an option to just, this is a better way for you. Yeah. You're not making a clear-headed decision. And I don't think 10 days is enough. Again, just a side comment, the amount of people going through MAID, I would argue, just from the limited knowledge we have so far, there is a minority of people, like a fraction, like a small amount of people, which I would actually entertain of being like, okay, maybe I'd be open if you want to do this. I don't want to be a part of it, but maybe I'd be open. The rest of them, I feel like it's more of a convenience factor than an actual. And there's also a mindset in terms of not wanting to push through or not wanting to fight the way through.
It was a little bit eerie for me this morning as I was watching a YouTube video on CBC's report on a lady who had anorexia and severe depression. And the whole report was about how the current government has postponed mental illness, as if that was your only reason. They've postponed that to 2027 to qualify for MAID, which I think is a good thing, so long as we have support for those people, because hopefully they don't just end their own life. Like, hopefully we give them support to help them through whatever suffering they're going through. But the comments was what was really heavy. I was going through these comments of these videos, and there's lots of people going, come on, just get it ready for me. I want it now. And then I click on their profiles and I watch their videos, and ordinary people. I don't know. Like, that's the danger of mental illness, I think, is that it can be hidden, it can be secret, it can be this. But I loved Rebecca's approach to that, going, well, then let's find other ways to support these people and break them free from whatever it is they're dealing with. But that was what was heavy for me, where I'm going, what? So it's for my point being, this might just be a form of suicide for some people, just straight suicide.
This might be controversial. I think that extreme depression and depression in general is tied to lack of purpose.
It's controversial for sure.
I do. I think that when you lose hope or you lose a purpose in life, that's when everything starts to
Actually, sorry, I'm going to take back what I said. What you said shouldn't be controversial.
It shouldn't be.
Because what you said is factually true, but if somebody listening only takes that as your sole reason for depression, that's where they're going to freak out.
I think, sure.
That's not what you said.
Imbalance and other things.
Exactly. That's not what you said. It's not the sole reason.
Again, I'm not an expert, people. I'm just giving my thoughts, but just from my experience, and I've dealt with a lot of people who deal with these type of things.
Yeah.
And it usually comes down to they just, whatever.
And I also want this to be said, is just as you were saying right now, is that this is not medical advice at all. This show is not to guide anybody through that process. It is to question the ideas in policy for government and what policies we bring in. If anyone's on the, I'll look right at the camera. If you're on the verge of unknown or what to do or deciding this, seek help, get advice, talk to
a loved one as well.
Like, talk to someone.
There's so much help that can come from talking to someone that loves you or that you love. If you don't have that, I feel very sorry that you don't have that in your life, but reach out to professional help or call a line or people who are amazing people that want to help you. Join a church. You know what?
I know.
There's probably 20 churches within 10 minutes of you. Go find one this Sunday. And go talk to a pastor. Tell them I need help.
Talk to someone and let them know.
They will help you.
For sure.
There's so many beautiful people.
For sure.
That's an awesome thing to do.
For sure. And when you look at the beautiful nature of what a church is, it's culture, it's support, it's help, it's a ear, it's a voice. Sometimes it's truth to call you out on what it is you're dealing with or whatever you might be dealing with. I do, as everyone watching probably knows, I'm a Christian, I'm a pastor. I believe in good and evil. And I do believe there's an evil force out there that does not value life and will do anything it can to devalue life and end it as fast as it possibly can. So get help, seek help, get to a church, get involved, plugged in. Even when you look at, and I don't want to fully unpack this right now, but when you look at cultures where there's, as you said, where there's purpose, where you feel like you are needed, where you have value in society, and then there's also community, they have some of the lowest disease rates, the lowest suicidal rates, the lowest depression rates of anywhere in the world. And I've explored this multiple times because that's one of the things that is so precious about a community like a church, is that it brings value, it brings purpose, it brings need, it brings accountability, and it brings the quality of life up in that environment.
Why is talking about depression in such a controversial thing in terms of giving thoughts like that? Like, the reason why I'm saying that, because if I think of myself, there's times in my life I would never categorize myself as being depressed, but there's times where you feel overwhelmed and feelings, and I could dive into that type of state where you feel no hope to jump out. Like there's when things feel heavy and there's times in your life you feel like you could, if I wanted to embrace that and dive into it, I could dive right into the deep end.
The
of it.
reason I think it's controversial is I think they would say this. I'm not saying I agree with this. I'm thinking they would say this. Is that there's no control, there's no decision in it. It's chemical, it's a disease, and I did not choose this, nor could I ever. And that's where I think the debate lies.
Yeah, and that there might be some truth to that. Again, not denying that. I'm just putting myself in this scenario of, there's been times, again, I would never diagnose myself as that, but you feel like, okay, I could embrace that. I could really wear that crown if I wanted to. But you know what? I've got my wife to think of.
Yeah.
I've got my son to think of. I've got stuff that I have to do in terms of that brings giant purpose to my life, in terms of we're both pastors and what we do with that, with the mission we have, with what we want to do with the work, with the family I want to build. Like, there's so many things that are outside of myself that keep me from getting locked inside of myself.
For sure.
And that's why I'm saying about this idea is that I do think a lot of people, at least from my experience you've talked with, end up falling into this depressive state because of a lack of purpose. They don't know where they're going. They're meandering.
And then it's a spiral where you
then they
lose
spiral
control.
down, inward focused.
One of the things Jordan Peterson has said I've followed a lot of what Jordan Peterson says and talks about in debates, but he's a clinical psychologist before he's into what he's doing now, and so he's qualified fully. But one of the things he started implementing was certain people who were dealing with depression. He started asking them about their diet and he goes, what do you eat? And he found out that they were malnourished. They had very little vitamins or any kind of supplements of any sort whatsoever. And so then he said, let's pause our sessions and start having 2 eggs in the morning with this. He gave them a couple things. And then they came back 4 or 5 days later and they were massively, dramatically better and more optimistic because they were missing basic B vitamins, cholesterol in an egg, protein. They were so deprived of protein that they couldn't even think straight. And so there's many variables to this.
Even what you're touching on, the idea of those are small accomplishments.
Yeah.
Like they probably got into a bit of a routine. It's going to sound funny, but like when I get like the whole idea of doing hard things, like that's relative.
Yep.
But like when I go out and accomplish something minuscule, like let's say you go out and you cut your grass and your lawn looks fresh. It's like there's a sense of satisfaction.
You'll go back and stare at it. Eh?
Yeah,
I know. You'll look at it and be like,
look what I did. This lawn is beautiful.
My lawn is so pathetic right now.
Well, mine's awesome. I let it grow out a little bit and I put some stuff and I put some extra seed.
Yeah, yours is flourishing.
And I was because I was like, I wasn't happy with the stupid water ban in Calgary. Made my grass.
Another show.
Yeah, another show. We're back on it, people. Anyways, my point is those little accomplishments stack up when you have little wins, doing the little things, is that helps a ton, I believe, with the whole idea of it. I don't know how we got off on this, but there is value in human life. And I think there is value that everyone can always contribute to society, no matter how bad a situation you might think, right? You have no idea the impact you have on other people, what other people are watching you, how they're watching you. I'm just saying is that there's this never say die type of attitude, which I don't want to lose as a society in a program or something like this that can slowly start to devalue life. But
absolutely.
Anyways, anything else?
Nope. Show goes on.
See you all later.